Welcome to today's deep dive. We're going to be tackling a pretty intense topic, tuberculous meningoencephalitis, or TBM for short.
Okay.
Yeah, it sounds pretty intimidating, but we've got some really fascinating material to dig into.
I'm ready.
Excellent. We're looking at notes from a presentation that was given by a doctor, probably to other medical professionals. So it's
Awesome.
like we're getting this insider's perspective.
I like it.
Yeah, and you wanted to better understand TBM, particularly how tricky it can be to diagnose the role of something called extrapulmonary TB, and also this growing concern about multi-drug resistance.
A lot.
Yeah, there's a lot to unpack here.
Yeah.
So let's jump right in. One of the first things that really stood out to me was just how hard it can be to actually diagnose TBM.
Oh, for sure.
It's like a real medical mystery, isn't it?
Absolutely. Even figuring out if someone has encephalitis or meningitis can be tricky because they can have so many of the same symptoms. And you know what's interesting? The presentation mentioned that only about 40% of meningitis cases actually get an etiological diagnosis.
Hold on, etiological diagnosis.
Oh.
For those of us who haven't been to med school recently, what does that actually mean?
Oh, good point. Good point. It basically means that doctors can't always pinpoint the exact cause.
Okay.
They might know it's meningitis, but they can't say for certain which specific bug is causing it.
Oh, I see.
It's like a mystery that remains unsolved.
Yeah, so that makes diagnosing TBM even harder then, I imagine.
Exactly.
So, okay, let's say someone comes in with symptoms that could be either encephalitis or meningitis. How can you tell the difference?
Well, that's where the detective work begins.
Yeah.
With encephalitis, you're more likely to see some pretty significant neurological problems, things like seizures, personality changes, or difficulty with speech or movement. Whereas meningitis usually presents with those classic signs like a high fever, stiff neck, and sensitivity to light.
Right.
But of course, there can be overlap, which is why it's so important to keep all the possibilities in mind.
Okay, so then where does tuberculosis fit into this puzzle? I know it's a lung thing, but we're talking about the brain here.
Right.
So-
And that's where it gets really interesting. Around 1 in 5 people worldwide have actually been infected with tuberculosis at some point in their lives.
Wow.
And roughly 10 million people currently have active TB.
Okay.
But here's the thing.
Uh-huh.
You don't always have to have obvious lung issues to develop TBM.
Wait a minute. You can have tuberculosis without it actually being in your lungs.
Exactly. It's called extrapulmonary TB, meaning the infection is found somewhere other than the lungs.
Okay.
The presentation actually mentioned a meta-analysis that found that more than half of the patients who develop TBM actually have the main infection somewhere else entirely, like lymph nodes, kidneys, or bones.
That's fascinating. I mean, and I'm guessing that makes diagnosing it even more of a challenge, right?
Oh, yeah, for sure.
If the symptoms aren't pointing to the lungs,
Right.
doctors might not even think to test for TB in the first place.
You're absolutely right. And to make things even trickier, the presentation talked about how TBM often progresses in stages.
Oh, okay. So walk me through those stages.
Sure. Imagine like a thief trying to break into a house. They're not going to just barge in, right? They're going to sneak in quietly.
Right.
TBM is kind of similar. The first stage, it's called the prodromal phase. It's very sneaky.
Okay.
Symptoms are really mild and non-specific things like fatigue, low-grade fever, maybe some headaches.
Okay.
This phase can last for weeks, so it's easy to dismiss it as just something else.
It sounds incredibly frustrating for patients.
It is. And then the meningitic phase kicks in.
Oh, boy.
And that's when things really ramp up. High fever, stiff neck, confusion, all those classic meningitis signs we talked about become much more obvious.
Okay. And I'm guessing the last stage is where it gets really serious.
Unfortunately, yes. The paralytic phase, it's a rapid neurological decline. We might see seizures, paralysis, coma, even death if it's not treated aggressively.
So TBM is really good at hiding then.
Yes.
But how does it actually even get into the brain? Isn't there like a barrier that's supposed to protect it?
There is. It's called the blood-brain barrier.
Right.
And it does a pretty good job at keeping out most unwanted guests. But Mycobacterium tuberculosis, the bacteria that causes TB, has a sneaky way of getting past it.
Oh, no.
It doesn't break down the barrier directly, but instead it forms these inflammatory clusters called Rich's nodules.
Rich's nodules. Those don't sound very friendly.
They're not. These nodules are basically like little outposts of infection within the brain and the spinal cord. They can cause a lot of damage.
Oh, God.
Think of it like this. They mess up the delicate balance of the brain, causing inflammation, damaged blood vessels, and ultimately those severe neurological problems that characterize TBM.
So the bacteria is basically waging war from inside the brain itself.
That's a great way to put it. And because of that, diagnosis is super challenging. Are you ready to dive into how doctors actually try to catch this sneaky invader?
I'm ready. Let's do it. It sounds like we've got our own medical mystery to solve here.
It is, because that's exactly what diagnosing TBM feels like, a medical whodunit, where you gotta gather clues from all sorts of different places.
Okay, I'm intrigued.
No single test is definitive, so it's all about piecing together the puzzle.
What are some of the key clues that doctors look for then?
Well, one of the first things they'll do is something called a lumbar puncture, which is also known as a spinal tap.
I've heard of that, but honestly, I have no idea what it involves.
Sure. Basically, it's collecting a sample of cerebrospinal fluid, or CSF, from the lower back.
Okay.
This fluid surrounds the brain and spinal cord,
Yeah.
so it can tell us a lot about what's happening in the central nervous system.
So what kind of information are we looking for in the CSF?
Well, in a TBM case, the CSF usually shows a few key things: low glucose, high protein, and a lot of lymphocytes, a type of white blood cell. But in the early stages of the infection, you might actually see more neutrophils, another type of white blood cell, in the CSF.
So the type of white blood cell can actually tell you something about how long the infection has been going on.
Exactly. It's one piece of the puzzle.
Got it.
Another tool doctors use is microscopy.
Okay.
They can use a special staining technique called acid-fast staining to try and actually see the Mycobacterium tuberculosis under a microscope.
Makes sense, but you said earlier that no single test is perfect.
Right.
Right. So what are the limitations of using a microscope?
Yeah. The main issue is sensitivity.
Right.
Meaning, how good is it at picking up on positive cases?
Right.
Sometimes, even if TBM is present, the bacteria won't show up under the microscope.
Oh, wow.
So it's not foolproof.
So what happens then?
Culture.
Hmm.
Growing the bacteria from that CSF sample
Yeah.
is the gold standard for diagnosis.
Okay.
But there's a big downside. It can take weeks to get the results back.
And in a condition as serious as TBM, weeks could be critical.
You're telling me time is really important, and that's where PCR comes in.
PCR, I've heard of that mostly with like COVID testing.
Right.
But how is it used to diagnose TBM?
Well, PCR, which stands for polymerase chain reaction, it can detect even tiny amounts of the bacteria's DNA in the CSF.
Okay.
It basically amplifies those genetic signals, making them much easier to find.
Oh, cool.
This makes PCR the most sensitive test we have for TBM right now, but like any test, it's not perfect.
So we've got the CSF analysis, microscopy, culture, and PCR. That's a lot of information to process.
It is.
Are there any other tests that doctors will use?
Yeah, another one that comes up is the ADA test, which measures the level of an enzyme called adenosine deaminase.
Okay.
Elevated levels of ADA in the CSF can support a TBM diagnosis,
Got it.
especially when you combine it with other findings. And of course, we can't forget about imaging.
Right, right. What role does imaging play in all of this?
MRI is generally preferred over CT scans when TBM is suspected.
Okay.
It can show signs of inflammation in the meninges, the membranes that surround the brain and spinal cord.
Right, right.
MRI can also detect things like hydrocephalus, which is a buildup of fluid in the brain, and any areas of damage or abscesses caused by the infection.
So it gives you a more complete picture of what's happening inside the brain.
Exactly. It's like having a roadmap of the infection's impact.
This is amazing. It sounds like diagnosing TBM is all about gathering evidence from different sources and then carefully putting the pieces together.
You got it. It's a process of elimination and very careful analysis.
Now, before we jump into the complications of TBM and how it's treated, let's pause here for a moment. We'll pick up right where we left off in part 2.
Sounds good. Welcome back. Before the break, we were talking about how doctors figure out if someone actually has TBM.
Right, right.
Now let's talk about what can happen if this infection isn't caught and treated quickly.
This is where it gets a little scary, right? What kind of complications are we talking about here?
Well, unfortunately, untreated TBM can lead to a whole bunch of problems. Remember those Rich's nodules we talked about?
Yeah.
They're not just sitting there doing nothing. They're messing with the brain's environment.
So what are some of the specific ways that damage can show up?
Well, one major concern is stroke.
Oh,
The inflammation and blood vessel damage caused by those nodules increase the risk of blood clots forming in the brain.
right.
And those clots can lead to lasting neurological damage, depending on where they happen in the brain.
That's a scary thought.
Yeah.
What else should we be aware of?
Seizures are another common complication.
Okay.
The infection basically disrupts the normal electrical activity in the brain,
Right.
making seizures more likely to happen. And then there's hydrocephalus, which we touched on a bit earlier.
Right, the buildup of fluid in the brain.
Yeah, exactly.
How does that connect back to TBM?
Well, the infection can interfere with how the cerebrospinal fluid normally flows,
Okay.
causing it to build up and put pressure on the brain.
Oh, no.
This can lead to headaches, vomiting, and even more serious neurological problems. And if the infection impacts the optic nerve, the nerve that's responsible for vision problems can happen too.
So it's like this domino effect.
Right.
One problem leads to another, and then potentially even more after that.
Exactly. It really shows how important early diagnosis and treatment are with TBM.
Okay, so let's talk about treatment. What's the plan for fighting back against this infection?
The treatment for TBM usually involves three main things: anti-tuberculosis drugs, corticosteroids, and close monitoring of how the patient is doing.
Okay, let's break that down. Starting with those anti-tuberculosis drugs, what are they exactly?
These are medications specifically designed to kill Mycobacterium tuberculosis.
Okay.
The typical treatment plan involves a combination of a few different drugs, each one attacking the bacteria in a slightly different way.
I've heard of some of these drugs, like isoniazid and rifampin.
Yep.
Are those part of the standard treatment for TBM?
You got it. Isoniazid, rifampin, pyrazinamide, and ethambutol are usually the first drugs used for TBM. They're typically given together for a long period of time to make sure that infection is completely gone.
How long are we talking about here?
At least 6 to 9 months.
Right.
And sometimes even longer. It just depends on the person and how they respond to treatment.
That's a big commitment. What happens if someone doesn't finish all of their medication?
That's a major concern because stopping the treatment too early or skipping doses can give those bacteria a chance to become resistant to the drugs.
Oh, I see.
And that makes the infection so much harder to treat.
That makes sense. So what about corticosteroids? What do they do?
Corticosteroids, like dexamethasone, are powerful anti-inflammatory medications.
Okay.
They help reduce the swelling and inflammation in the brain caused by the infection.
So they're not just going after the bacteria, they're also trying to fix the damage the infection is causing.
Exactly. It's a two-pronged approach.
I like it.
Now, corticosteroids can't prevent every potential long-term complication of TBM, but they have been shown to significantly improve survival rates.
That's good to hear. You also mentioned keeping a close eye on the patient during treatment.
Right.
Why is that so important?
Well, there are a couple of reasons. First, doctors need to make sure those medications are actually working and that the infection is responding.
Right, I got to make sure those bacteria aren't figuring out how to survive, right?
Exactly. But there's another reason close monitoring is so important. Something called paradoxical worsening.
Paradoxical worsening. What is that?
It sounds kind of strange, but as the body starts fighting back against the infection more effectively, the patient's symptoms can actually get worse for a bit.
Really? So it's like a sign that the immune system is finally waking up and doing its job.
That's a great way to think about it. But it can be a little scary for patients and their families if they aren't expecting it.
Right, for sure.
That's why keeping a close eye on things is so crucial, to make sure everyone understands that it's often a normal part of healing and not a sign that the treatment isn't working.
Okay, so we've talked about the infection, diagnosis, the possible complications, and the usual treatment. But we can't forget about multi-drug resistance.
Right.
How big of a problem is that when it comes to TBM?
It's a growing concern all over the world, and it definitely adds another layer of complexity to dealing with this already tricky infection.
How so? How does drug resistance actually change things?
Well, when those first-line drugs we discussed, like isoniazid and rifampin, aren't effective anymore, doctors have to start using what we call second-line medications,
Okay.
and sometimes even third-line options if the resistance is really bad.
Right.
Unfortunately, these other medications aren't as good. They often have more side effects, and they require even longer treatment periods.
So it's like trying to fight a tougher enemy with weaker weapons.
That's a perfect analogy. It really highlights why it's so important to understand what increases the risk of resistance in the first place.
What are some of those risk factors then? What makes someone more likely to develop drug-resistant TBM?
There are a few things to consider. If someone's been treated for TB before but didn't finish all their medications, that can really increase their risk of developing resistance.
Right, because it gives those bacteria a chance to learn how to survive those drugs.
Exactly. Another risk factor is being around someone who has a known case of drug-resistant TB.
So it's almost like catching a superbug from someone else.
Yeah, that's a good way to put it. And lastly, traveling to areas where multi-drug resistant TB is common also increases the risk.
So it's a combination of personal behavior, public health measures, and global trends.
Exactly. And it shows just how urgently we need new research to develop better treatments for drug-resistant TB.
Okay.
We've gone over a lot in this deep dive, but there's still more to discuss.
Of course.
We'll talk more about some of those details of treating drug-resistant TBM after the break.
Sounds good. We're back and ready to wrap up our deep dive into the world of TBM.
Perfect timing.
Right. So before the break, we were getting into the nitty-gritty of treating drug-resistant TBM.
Yeah, the tougher cases.
Right. And you were about to tell us more about what happens when those go-to drugs just aren't cutting it.
Right. So when those first-line medications, those big guns like isoniazid and rifampin, stop working, doctors have to switch tactics and turn to what we call second-line drugs.
Okay.
And sometimes even third-line options, depending on how resistant those pesky bacteria have become.
You mentioned earlier some of those medications that are used, some pretty intense names, if I remember correctly. Can you remind me what those are and how they work?
Of course. So some of the common second-line drugs include medications like fluoroquinolones, which work by messing with the bacteria's ability to copy its DNA.
Okay.
And then there's linezolid, which disrupts how the bacteria make proteins.
Got it.
And if those are effective, doctors might have to consider injectables like amikacin or capreomycin.
Okay, so those are kind of like our backup options when the initial defenses fail.
Right.
But you mentioned earlier that these alternative medications aren't quite as ideal as the first-line drugs.
Unfortunately not.
What are some of the downsides?
Well, one issue is that they just tend to be less effective overall. And they also often come with a greater risk of side effects, which is a big concern with TBM, considering how delicate the brain and nervous system are.
Yeah, that's a tough situation for both the patient and the doctor. You're fighting this tougher opponent, but your weapons aren't as strong, and you have to be incredibly careful about collateral damage.
Exactly, you put it perfectly. And to add to the challenge, the treatment courses for drug-resistant TBM are way longer.
Oh, no.
We're not talking 6 to 9 months anymore. It can be 18 months, 2 years, or even longer.
That's a very long time to stick with a treatment plan.
It is.
It must be so difficult for patients to stay committed for that long.
You're absolutely right. Sticking to these tough treatment plans for such a long time is a big challenge, and it's something healthcare providers really focus on.
What are some of the things that can help patients stay on track with these difficult treatments?
One common approach is what's called directly observed therapy, or DOT.
DOT.
Basically, a healthcare worker watches the patient take their meds every single day.
Wow.
This makes sure they're taking them correctly and not missing any doses.
So it's like a combination of accountability and support.
You got it. And DOT has been shown to be really effective in helping people stick with their treatment plans.
That makes sense. I know DOT isn't always possible, but are there other things that can help?
Definitely. Patient education, counseling to address any worries or fears they might have, and building strong support systems are all really important.
So treating drug-resistant TBM really requires a team effort.
Absolutely. Patients, doctors, nurses, pharmacists, social workers, everyone plays a role in achieving the best possible outcome.
Well, it feels like we've really covered the bases when it comes to TBM.
I think so.
We talked about how hard it can be to diagnose, what happens if it's not treated, and the complexities of treating it, especially when drug resistance is involved. Anything else you'd like to mention before we wrap things up?
I think the most important takeaway, as the presentation emphasized, is to be suspicious early on. Even if there are no obvious signs that the lungs are involved, if a patient is experiencing those early symptoms we talked about, the fatigue, low-grade fever, headaches, it's critical to consider TBM as a possibility.
So even if it seems like it might not be TBM, it's better to err on the side of caution and get checked out.
Right, because catching it early can make a big difference in the long run.
I see.
And the other thing is, when it comes to diagnosis, use every tool available. Don't just rely on one single test or piece of information. Use everything, the CSF, analysis, imaging, cultures, PCR, to get the full picture.
Great advice.
Yeah.
This has been a really eye-opening deep dive into TBM.
It has been.
I always like to leave our listeners with something to think about, so I'm curious. Given how difficult it is to diagnose TBM, what do you think the future holds? How will research and technology make this process faster, more accurate, and better at saving lives?
That's a great question and one I think about a lot. I think we'll see a lot of advancements in rapid diagnostic testing, even point-of-care testing, that could provide results in minutes or hours.
Wow.
And I'm hopeful that new drugs will be developed that are more effective and have fewer side effects, even against those resistant strains.
It's an exciting time to be in medicine, then. It's been fantastic having you here today. Thank you so much for joining us for this deep dive into tuberculous meningoencephalitis.
It was my pleasure.
And to all our listeners out there, be sure to check out the links we've provided for more info.
Yes.
Until next time, stay curious.